All right, Stefan Hartman here, Iron DPC podcast, bringing you a new expert this week. This is Dr. Randy Ortiz. He is a doctor of physical therapy. He has a clinic up in Apopka, Florida. Randy, thanks for joining us.
No problem, and it's my pleasure to be here with you, Stefan.
Cool. So you found me on Instagram. You found my story of my tennis elbow story, and you found that was quite unconventional and interesting. And we then started speaking, and I found that you have also an unconventional approach to physical therapy. So, I want to ask how you really got on this journey. I know you were traditionally trained doctor of physical therapy. What kind of brought you on this journey? What made you change the way you approach patients?
Yes, right. So as a traditional program, we've learned all the basics about muscles, nerves, anatomy, whatever the case may be, patient care. And so, but it didn't really start changing for me up until my clinical experience. I remember there was one specific experience that changed my whole outlook and how I wanted to approach patient care. And so what I noticed as a student was that in traditional model, there were 3 to 4 patients per physical therapist an hour. And so I'm thinking, how are we supposed to deliver the best top-notch care to these to the patients, to these individuals that are trusting us with care, that they're going to provide the best possible? And it's hard to do that when you have 4 people in the hour, and each having its unique diagnoses and its unique intricacies with each person. And so you cannot just treat everybody the same. But one thing I saw was that a lot of people were being treated the same. And so there was this one clinician that had this patient with back pain. And so I had seen what this individual was doing, and the person kept coming every single week, 3 times a week. And I didn't see no change in what the patient was verbalizing from the back pain. So one day the clinician had a meeting to attend to, and I was told, Randy, take care of this client. I was like, sure, no problem. I only had this client for 1 hour. Since I was a student, in this moment, they only gave me 2 patients the hour. So I was like, sure. So I was able to treat this client, focusing on the person that was in front of me, understanding what was their needs, understanding what was their pain and where was it stemming from. By the next visit, the client was 65% better. The client was able to walk and experience no pain while walking, only experienced pain during heavy lifting. And while the client came back and was telling this to the clinician that was working with them, the clinician come back to my clinical instructor and told my clinical instructor, hey, I don't want you to keep this patient anymore. I want this patient to be transferred to Randy because Randy made me look bad in front of the patient. I had a plan for this patient, and Randy completely turned it around. It's not, this was not what was supposed to happen for the patient or whatever. And so they gave me the patient. The patient got better. End of story. Happy. The patient was able to leave with less visits than they thought they needed. The patient did not need 25, 30, 35 visits. The patient most likely only needed 6, 10 visits. However, because of the traditional model and insurance limiting the amount of people, like insurance limiting the reimbursements and having so much oversight, it actually limits on what businesses can do. And so healthcare turns into a business model rather than a healthcare model. And so patients are suffering more than the business is. And so I've decided to go on my own and make a change, be able to make a change in people's lives so that they don't have to leave their job 3 times a week, spend their money because they're not working at work. They have to now leave early. They have to drive. They have to, be in the waiting room, and then I get to see them. And all of that adds up eventually. So I have decided to just treat patients one-on-one on a model that They have gotten much better quicker, 4 visits, 6 visits, depending on the diagnosis, depending on the patient, and depending on the patient provider relationship. Because if the patient is not willing to do their part of the care, then I'm just gonna be honest to them and be like, we are not a great fit for you. We work with people that want to be healthy, that want to be able to live life, and have life under their control again.
Yep. This is kind of like the same everywhere in the industry. Is we're trying to see as many patients as we can. Click all the boxes. Bill the insurance. Crank them out. See 30 patients a day, 40 patients a day, and that's how businesses run. But the patients don't get better. They have to come back all the time. They have to get the surgery, the injection, the physical therapy. Oh, and it's just again and again and again. It's an endless circus, is what medicine is. And I'm glad you've kind of figured a way to, go on your own. And patients need to understand this, that you can go through the insurance system, but you're not going to get better. You need to sometimes, you have to do outside of it, which is what my model is, which is your model is. We're outside the insurance industry because we actually want to fix people.
Right.
Make them better.
Right. We want to give them a better life.
Better life. That's right. Very interesting. So
yeah. Let me give you a quick story before you say that. Today, I was actually seeing a patient in one of, I do home health part-time for a private company while I'm starting to kick off my own branding of biorehab. And it was so amusing to me. All the patients that receive corticosteroid shots. And that's it. They just get shots. They don't tell them about the side effects of possible osteoporosis and ligamentous changes with corticosteroids and all of these things. And when I looked at the patient today, I'm like, do you realize this is not your knee? Do you realize this is coming from this specific muscle? And I do some different techniques with my manual therapy. She was limping when I saw her today. I only gave her 10 minutes of the manual therapy, and she did not feel the pain whatsoever. But the same pain that she went in to get corticosteroid shots that did not alleviate it, I was able to decrease it in those 10 minutes, and allowing us to strengthen and improve that coordination, that neural drive running through those muscles to have that muscle memory. So when I am not there, she doesn't need my hands. She's able to be able to take care of that herself.
Wow, so cool.
Yeah.
Well, it's probably often misdiagnosis is what I've seen. I actually worked in pain management and spine. A lot of these patients that came into us, they just didn't get the right diagnosis. So they didn't then get the right physical therapy because, they didn't know what was wrong. The other providers didn't know. But there's certain things, there's always a couple of certain things. And it's, you have to find the right diagnosis and then you're going to get the right therapy. Maybe it includes a corticosteroid, but then it should always include physical therapy every time.
Right. And that's so I saw people not doing that. No. I saw doing that, not doing that. There's a place for corticosteroid shots for sure, 100%. But I did not see where after corticosteroid shot, they will go to therapy. It would be corticosteroid shots, 2-3 rounds, and then maybe therapy.
Yeah. Mistake. It should not be done like that. No. Very cool. So your training was at a Seventh-day Adventist center, right?
Yes, correct.
Very interesting. I almost went to a program like that for PA school. I'd applied to Loma Linda University. Applied twice, went on 2 interviews. They both didn't accept me for some reason. Okay. It may be because I'm an animal-based practitioner. I believe in the meats heal. And so what was your education there? Did they teach you on nutrition there?
So it's funny because nutrition was barely a topic, but I knew my professors did not eat meat. Okay. And so they did bring one time a nutritionist to speak for the class. And it was supposed to be a non-biased class. And it was supposed to be to teach us more or less the different type of diets. But as they introduced the different type of diets, this nutritionist, everything was evil, everything was bad, everything caused inflammation in your body except the vegan diet. The vegan diet was the only one that decreased inflammation in your body, the only one that improved circulation, the only one that improved healing, that improved on neural recovery. All of that was just through the vegan diet. Never did not hear anything positive about any other diet. No paleo, no nothing. Whatever the case may be, just put a blank and then cover that. Everything was evil unless it was 100% vegan. And evil in the sense not morally, but just evil to your body, like it was hurting yourself. But this nutritionist was not Adventist. This nutritionist was not associated with the school. It was a third party.
Yeah. Well, a lot of these nutritionists, these RDs, they come out a bit indoctrinated because all of these studies, if you look at this Nurses Health Study, Epic Oxford, all of them, they all focus on like a vegan agenda and they biased towards that. So it's a product of their training, but the Seventh-day Adventists specifically fund a lot of these studies, right? They create, they have the academic institutions, they have the funding for the research, they create the researchers in the first place, and then they go out and do the research and they find the positive association with the vegan diet. But this has a lot of political and religious drive behind it, a lot of monetary drive behind it, because the SDA is associated with the cereal brands, the Kellogg cereal brands. So there's a huge financial incentive to promote a grain-based diet for financial reasons, you know, besides the religious reasons that the SDA promotes these methods.
Right.
But hey, at least you got nutrition training. That's more than I got.
But it was biased. So.
In PA school, and medical students, they don't get, PA students, nurse practitioners, they don't get medical nutrition training. And if they do, it's the same thing. Avoid saturated fats, meats bad, meats cause cancer. That's it.
Right. And that was the main focus too. Vegan diet, decrease cancer, you know, all around. So I was just like, okay. I stopped listening halfway through because I knew how biased it was.
Yeah. Wow, cool. So you are doing sounds like at-home visits, or they come into your office there?
So I do both, depending on the patient needs. Sometimes I will go into their home. There is a slight fee associated with that, being that I have to drive to their homes, but they could come in here into the facility. We can treat them here. And sometimes we do a hybrid model where if I don't think I need to see you bi-weekly or even in a month, I may just create this program for you and I'll be following with you weekly to see how you are. And if I do need to see you in person, I will, just to see how things are coming along. But all my clients have access to me weekly.
That's awesome. That's awesome. So people are going to get better that way with the direct access to their care provider. That's the whole concept behind Iron Direct Primary Care. They have access to me. They can text me, message me. I do in-home visits, telemedicine visits. It's really comprehensive. I'll go to their houses sometimes, do like a nutrition inventory, where I look through their kitchen. What are they actually eating here? What's causing the inflammation in the first place? We look through everything. And then, yeah, we look at their functional ability. We look at their posture. What's their range of motion like? How are they sitting? All of these things that, you know, drive pain, chronic inflammation, spine problems, degeneration. It all works together. Nutrition, the mobility, their muscle capacity. It'd be good knowing someone like you. I can refer patients, you know, who have, you know, bad problems, bad postures, poor biomechanics, who just need a comprehensive functional change to improve their capacity to live. Right.
And that would be amazing. I would appreciate that. One thing that we really address when we do patient care, we've noticed from a neurological standpoint, everybody comes in different shapes and sizes. And so what we've noticed is stresses that we feel. So part of our evaluation is actually, we're asking them, how is your life? How is your stress levels? You know, how is life like for you right now? How are you feeling? Because we've noticed that a lot of patients with high stress, especially if they have shoulder pain, will come up like this to us constantly. The phrase that people carry stress on their shoulders is very true. I've noticed them, very high anxiety patients would come in like this, and we'll have to talk through them to help them relax and see if there's any changes with just addressing that proponent. Now, we're not mental health counselors or anything like that, but definitely I am a human, and I could listen to another human speak about their problems, and sometimes we just need to release. And once they release, some of my patients will be like, oh, my headache feels a little bit better, or the tightness in the back of my neck just feels a little bit better. It's not going to fix the issue, but I do understand that that's part of the issue. So, we talk about sleep cycles. Are you sleeping? Are you sleeping 8 hours, up to 9 hours sometimes? Are you able to do that? 7.5 hours at least, at minimum. I would appreciate 7.5 hours of sleep. We understand the circadian rhythm is very important for general health. And so we take a look into the whole body and their activity level and what they're doing. And we begin to make small changes here and there. And what we can, we try not to throw everything at once to the patient. We try to just address little things here and there. And obviously our specialty will be the movement part. But, if we only address the movement part, what we realize and what we find out is that problems do come back if we don't address all these other issues.
Yep. I agree.
So,
it needs a comprehensive, integrative approach. Chronic pain is a huge problem in the US. Everyone has some level of pain, and people live on opioids for most of their life. They go get back surgeries. The back surgeries don't make them better. They have to go in every couple months to get another rhizotomy procedure, so burning up the nerve, or a steroid injection. It's a constant cycle. And it takes a comprehensive approach to fix someone.
Right. I actually have a patient right now that she had a rhizotomy procedure. And so, I advised this patient about the pros and cons for that. But I did not think she was a great candidate for this. Needless to say, she genuinely believed that she was gonna be in no more pain after this. I told her, I'm like, that's not where the pain is coming from. You may feel that side of your area may feel better, but I know that there's gonna be another area that is gonna be feeling it.
Right.
She, I respected her decision. She moved on with the problem. She called me 3 days later. She's been in the worst pain she's ever felt. It was an emergency call. I went in. I helped her coordinate certain motions with her hip and her low back. We were able to bring her pain from a 9 to a 3, which was way more livable than what she was at that moment. But even then, the adherence from the program is still not there. So, there's a certain point where I do tell my patients, like, unless you're able to implement this in your daily life, because you're not going to take me home with you. I don't live with you, right? I can't wake up every morning and lead you into a new lifestyle. Unless you're able to take full control of your body and your health, your life won't be feeling, this pain will not go away.
No.
Mm-hmm.
So yeah, what we're talking about here is degeneration of the spine. So typically the spine has some space in between it, but people who get degeneration of the spine, their spine starts to compress, and then they'll start getting these joints that start rubbing together, and these joints cause inflammation. They can pinch off a nerve that exits there. And then what the pain management does, they go in and they burn the nerve signal. And usually that can take away the pain, but it's always temporarily, because the nerve, it grows back. Now, if sometimes you go after the burning of the nerve and you do the chiropractic and the physical therapy, you can sometimes break up the adhesion, and sometimes it can be a good solution. But from my experience, patients always need to get the rhizotomy every about 6 months is on average when the nerve grows back. How would you go about fixing something like that? So like degeneration of the spine, facet syndrome. So it doesn't always come back all the time.
Right. And so, reading into, doing more reading into this, I've actually come across into that we can't really manipulate much of the spine. The spine is a very strong structure. Even if I were to push against it, I'm doing minuscule movement into the actual vertebrae and the actual facets, that they're not gonna really provide a much of a long-term change. What I have realized is that pain, if it's there, is because it's a chronic issue. And one thing we know about chronic pain is that in the cortex, there's smudging of the cortex when it comes to chronic pain. There's an actual change in the structure where the signals come from in that area that is not as clear as it was before the chronic pain. So what I've realized through this is that patients begin to kind of disassociate, like that part of their that part of the spine where it hurts. It's like it doesn't exist anymore, and the only thing that exists is pain. And so my job is to begin to introduce information into the area, to begin to send that information back into the cortex and somehow relieve this smudging that occurs. Now, how I'm not able to do that in a week. I'm not able to do that in a month. This has to be a lifestyle change for the patient. However, what I am able to do is stimulate the sensorial nerve feedback. And what is that like? That is my manual therapy. That is some touch. That is maybe some vibration. I am no way breaking apart scar tissue. My hands cannot break apart scar tissue. My hands cannot do a lot of structural changes, but I can provide some sensorial feedback, which promotes that information to drive up the brain and say to the brain, hey, we're okay. We're not in pain. We're actually okay. Because chronic pain, you find out that the structure is okay. There's just inflammation. The inflammation process never stopped. It just kept going. But the structure itself is not damaged. So when I'm able to do that, I ask the patient then, okay, let's move through this new range while I'm still applying my hands. I'm doing it with movement. It's not a static thing. It's not like my patient is lying down on the table and I'm just massaging them and that's it and I'm done. No, I'm applying the pressure while the patient is still moving the hips, while the patient is still moving the legs, providing that sensorial feedback with motor output. And then little by little, the patient is able to move through these ranges and able to have that muscle memory. However, what we find out is after a couple of weeks, the brain comes back and gives you a flare-up. And it says, well, we're in pain again. And the patient gives me a call and it's like, I'm 9 out of 10 pain. Everything came back all over again. And I'm like, I told you this was gonna happen. It's okay, there's nothing wrong. Let's go back and let's introduce that sensorial feedback again. And so it goes, instead of happening 2 to 3 weeks, now it goes on 2 months without a flare-up. But now the patient understands what to do when they're having a flare-up and how to manage it without needing me. Because I don't want the patient to rely on me. I always give them the tools and how to decrease this pain.
Wow, very cool. So I've worked with back surgeons before. And so what back surgeons often do, they get a patient with back pain, maybe got back pain sciatica, for example. Oftentimes the surgeon will put a patient through physical therapy for some time, but usually that fails. And the solution, they say, is the back surgery. There's many ways to do back surgeries. I've seen them done very well, and I've seen it done very badly. Do you have have you seen good resolutions in sciatica, like nerve impingements or radiculitis with what you're doing for patients?
Yes, when I have a patient that is all in the program and is willing to take care of their health, I've never, they'll have flare-ups like once a year, but that's it. Like they're able to live their life normal. For example, I'm myself. I'm gonna talk about myself because I do have sometimes back issues. One time, I have a 102-year-old grandmother. And so before I was a physical therapist and knew how to do things, I tried moving her. I did the worst possible movement and I completely popped my back. Oof. And I was in bed. I could not move a single muscle. That was horrible. Ever since then, I do get maybe once or twice a year, a slight, like I feel some slight disturbance in my back. And I know if I don't begin to work in that area, if I don't begin to do some exercises to provide some feedback in that area, I will get the same pain again. So it's more like managing rather than rather than it's a one thing fix all. Because even the surgery, if you did nothing at all, you will still get the pain back. Every single person that I've seen with a low back surgery, sadly, their sciatica comes back because they think that once the procedure is done, once that 3 weeks of therapy is done, they never have to exercise ever again in their life. And that's completely mistaken. That is completely dangerous. No one is addressing the fact that there needs to be a lifestyle change.
Yeah.
Especially if there's like comorbidities like diabetes and you know, high blood pressure issues and all of these. This can only exacerbate the issue even more.
Sarcopenia being the huge one, so the muscle wasting. So I always thought about this in spine. I'm seeing these patients and their muscles, there's nothing there. All I do when I'm pushing on their buttocks, they have no butt. I'm just pushing right on a very thin piriformis that's constantly painful. There's no muscle mass on these people. There's just fat bellies. The fat is sagging. There's no muscle. So we then do the surgery. Yeah, we fix the pain. Okay, say we did great surgery, it fixes the pain. But in my head, I'm thinking, well, what caused this pain in the first place, right? And it's probably because sarcopenia, they have no muscle to support their spine. So we do the surgery, and I'm pretty sure they're gonna do something else down the road.
Mm-hmm. Right. And so you actually pinpointed one of the biggest muscles that we definitely have to work out. It's the butt, right? It's the glutes. So you touched the piriformis, which seems to be kind of like a trigger point.
Oh yeah.
Do we understand why the piriformis is such a trigger point for many people? Because it starts to do the work of the glute max. The glute max is a huge muscle. The piriformis is like this.
Tiny.
It's tiny little thing.
So tiny.
And it's so a tiny little thing, right? And so you know, and so when this muscle has to do the work of this big muscle, it goes into spasm, puts pressure against the sciatic nerve. Yeah. And as we know, there's a different variation in how the sciatic nerve can go through. And sometimes it pierces the piriformis, sometimes it's go behind the piriformis, and there's different variation in anatomy. But whatever the case may be, if that piriformis goes into spasm, it will put pressure against the sciatic nerve. And so when we address the glute max and we really incorporate more neural drive into that glute max and more endurance-based programming instead of just hypertrophy strengthening, then that endurance-based programming would allow the glute max to keep kicking in and the piriformis can learn to relax.
Yeah.
You know? So I agree with you. Sarcopenia is a huge problem.
It's so problem. And I think part of it is the nutrition dogma that's been pervading our society for the past 50 years. It's eat less meat, eat more veggies and low quality proteins. So people eat like a standard diet. When I ask like an older person, they eat like a toast for the morning, maybe a bit of an apple juice or yogurt. And then lunch, I don't know, maybe a sandwich at Panera that has like a bit of salami and mostly bread. And then dinner, yeah, maybe dinner I'll have some fish sometimes or a steak. But like the diet is so poor in nutrition, poor in good bioavailable sources of protein, that they're not eating enough meat, first of all. And so your muscles are going to waste away. And then second, they get very minimal exercise. They're barely walking. They might say, oh, for exercise, I walk at work. And that's pretty much the extent of what most people will do. So you got no protein, you got a carbohydrate-rich diet, you got no exercise, and your muscles are failing. You can't get off the ground. Your back hurts. That's what we got.
What you gonna do? Right. And so I understand that dieting is such an important aspect, and you hit it right there. Almost you literally said it, what I heard multiple times: a toast in the morning, maybe something small in the afternoon. It's like, what are you eating? You know?
Barely surviving, barely getting enough calories in to survive. But then these people are also overweight too. They have a lot of fat mass. And it's mostly because they have an imbalance of muscle to fat. And when you get in a cycle of the high fat mass, it drives sarcopenia because it drives high estrogen, it lowers testosterone, and then you can't break this cycle. It's a perpetual cycle that people get stuck in. of low nutritional density or no and high calories, or even like normal calories. People will say, oh, I'm barely eating, but I'm still gaining weight. And it's just because they have high fat mass, a low muscle mass. And so they have low caloric expenditure at baseline from low muscle mass, as well as low caloric expenditure.
Mhm. Right, right. No, I agree 100% with what you're saying. That's definitely part of it.
Yeah.
Yeah.
It does need to be part of a comprehensive plan, whether it's part of the physical therapy plan or part of the primary care plan. It's nutrition needs to be for the foundation, and then the exercise component in addition to this.
Right.
But unfortunately, as we both found out, we don't get this nutrition education in our training programs.
Yeah. Not at all. Not at all. And when last time I went to the primary care, it's like just make sure you're eating enough veggies and enough fruits. But like they don't even care enough to even stress the idea. So most people don't even act, because I'm like, my primary care doesn't care about enough about educating me about this. Why should I care about it?
Yeah.
Because they make it seem like it's not that big of a deal. Like, who cares if you don't eat that much, fruits into your diet? Who cares? Like, whatever. And so if the primary care doesn't care, that's gonna transfer down into the patient.
Primary care doesn't care because he wasn't educated in the first place. Primary care is also probably 50, 60 pounds overweight and doesn't exercise because he's too busy clicking through the buttons 2 hours after work to finish all the charts and bill insurance for the 40 patients he saw earlier that day.
Right. And it's great talking to you, because we come from different parts of the healthcare field. You've had your experiences with that, and so I know primary care see a lot more patients than we see in a day. Because they see one patient every 15 minutes, maybe less. And so they're constantly being burned out in the field. And so physical therapists too. But it's great that we both have come into this conclusion that something has had to change. And just, people can't just, we can't just work, because life will be, quote unquote, a little bit easier for us to just go through the motions of life and just go do I could do my easy exercises. You could just prescribe what you got to prescribe and click, and go through the motions. And yeah, we could get burnout, but it is what it is. And that's what most people are doing. But what's hard is taking a stand against the mass. That's what's hard. What's hard is having a voice that's different than the rest, because we know that we're going to get so much negative feedback from people that people are going to be like, shut up, stop talking. What are you doing? But we know we do this because we have something that is valuable and that people need to hear. And that people, if they do this, people will come out stronger on the other side.
So true. It's great talking to you and hearing your side of this as well too, and your great things that you're doing here, and changing the industry. It's going to take more providers like us walking away from the sick care system and doing our own thing, and people are going to start recognizing, should I just use my insurance and go there? Is easier, or should I come and find someone who is a little bit unconventional and maybe will make me better?
Mm-hmm.
And there's gonna be more providers like us walking away, because more providers are seeing that patients aren't getting better. They don't want to click boxes all day and just bill insurance. No one wants to do that. They don't want to. We went into medicine to make people better, not click boxes.
Right. Exactly. And that sadly is what medicine is turning into. And so it's up to us.
Amazing. So Randy, where can people find you if they're looking for a great physical therapy?
Yes. So we're at 1122 Piedmont Lane. You can definitely find us there, or you could definitely message us online on randy.ortizm. That's my Instagram. Or the Bio Rehab. The Bio Rehab is our company, and you could DM us there, ask us any questions. We'll be more than happy to answer your questions. If you need to see us, we'll talk through it, and we'll see what we can do to get you seen.
Do you have a website for Bio Rehab?
The website for Bio Rehab is thebiorehab.com.
Oh, thebiorehab.com. Okay.
Yeah, thebiorehab.com. Yep.
Great.
And so, yep. And so currently the website is having some changes as we're going to be adding some new programs within the next couple of months. So that's still, certain things are under construction, but you could see us at the website, or you could see us on Instagram, where we are most active.
Perfect. All right. I'll stop recording here. Thank you.